Olá, sejam bem-vindos à TV SBU, na cobertura do 16º Congresso Internacional de Uro-oncologia aqui em São Paulo. Eu sou Bárbara Melão, urologista, e estou aqui com o Dr. Spiess, professor de urologia nos Estados Unidos. Thank you very much for being here with us. Well, it was a very great session about urotelial carcinoma during the whole day, actually, since in the morning. But now in the afternoon, you talk a lot about upper tract urotelial carcinoma. So, I'd like you highlighted the importance of lymph node dissection for these patients. So could you please talk a little bit about that?
Yeah, sure. So first of all, thank you for the invitation, and it's wonderful to be participating in this session and just sort of discussing some of the take-home messages from the talk. So I think a lymph node dissection in upper tract disease for many years has really not been something that has got enough attention, just because, unfortunately, not like bladder cancer, it has not been really studied as a rigorous way in a prospective studies. But I think we have good data, as we're discussing, that based on the stage of the tumor, as you go to patients who have bulky tumors, T1 or greater, the incidence of having node positivity can go up pretty dramatically, up to 20 to 25% for T2 tumors. So I think, particularly in high-grade tumors who are, I would say, you suspect may be invasive, it should definitely be something that you think and consider doing it and sort of discuss with your patients. I think the important part related to lymph node dissection is when should you do it and how should you do it. So, I think it could be done robotically, it could be done open. I know that some of the controversies have sort of come when sometimes you have to, or you consider doing a more elaborative lymph node dissection, including intra-urticable lymph nodes, for example, much like in testicular cancer. If you feel you can still do that using a minimally invasive robotic approach, it makes sense. I think we have a good idea of what the template of dissection is today based on some nice work out of Japan and also some work we've done in collaborations, that in most part, the template dissection should really be done based on the site of the disease. So if it's right-sided disease, upper tract, renal pelvis, proximal ureter, up to mid-ureter, including the retrocaval, paracaval, the perihilar lymph nodes, and extending to the intra-urticable lymph nodes, and really doing as a template to include up until the right common iliac. So that would really be a standard lymph node dissection. On the left side, I think the intracaval does have value as well, because there can be crossover, and usually including the periaortic, retroaortic, perihilar, same thing, the common iliac lymph nodes on that side is really a standard template, and that should pick up about 90 to 91% of lymph nodes.
Great, amazing. Well, and what about neoadjuvant therapy for these patients? Recently, about last year, I guess, led by Dr. Coleman, the guidelines of upper tract disease was revealed. So what did it say about it?
Yeah, so that's a really good question. I think neoadjuvant chemotherapy is something we should think of doing. I think particularly patients who have locally advanced tumors. Again, if you think this is a sessile tumor, it's high grade, I think it's important to, at the very least, have in the back of your head that it may be something you should offer to patients. And the other factor related to it is what you anticipate the renal function of the patient is going to be postoperatively. We know that obviously platinum-based chemotherapy, which is still gold standard today as our systemic regimens, require good renal function. So if the patient has, I would say, borderline renal function, sometimes you're best to give neoadjuvant chemotherapy first, then do surgical resection. And I think if you do it, I think the toxicity is really quite low, and then consolidative surgery would obviously be beneficial to patients. There's a little bit of debate now, are you better to do neoadjuvant or adjuvant? But I think if you use those factors of identifying the patients who are high risk, in particular patients who maybe compromise renal function, I think sometimes you can better sort of select which patients may benefit from that.
Very good. And when you perform an nephrectomy, do you do the intravesical chemotherapy after the surgery?
Yeah, and I think that's really an important part of the treatment of these patients. It's very interesting. We did a study most recently as part of this large collaborative of 6 major centers across the US treating upper tract disease, and there's still centers where they don't give perioperative intravesical chemotherapy, but the data is very compelling. We have prospective phase 2 studies which have really shown that if you use perioperative intravesical chemotherapy, usually today it's mostly gemcitabine that we use, it decreases the risk of recurrence. The way I like to give it, and it can be done many different ways, I like to give it usually on the first postoperative day for the simple reason I like to see and get a JP creat, make sure there's no urinary leak where I did a bladder cuff. And usually I will test the fluid. If it's negative, then they'll give it on the floor within the first 24 hours. I do think there's value of potentially even giving it in the operating room while you're doing the nephroidectomy and specifically the renal component of the surgery, so that all those agents are sort of in the bladder and immersed while those cells are potentially being shed and deposited within the bladder.
Very good. And what about adjuvant therapy for these patients? And what's the role of immunotherapy for these patients?
Yeah, so really good question as well. Is I think if obviously patients have not received neoadjuvant treatment but have a high-risk tumor, T3 or greater, or N positive, there's no role, based on the POUT study, those patients will have a significant improvement in disease-free survival from getting GemCis or dose-dense MVAC. GemCarbo, a little more subjective, although if you look at this paper that was published, GemCarbo still had a benefit. I do think there's a little bit of a selection bias there. Related to immunotherapy, we were just talking about that in that session. I don't think it's very well studied in upper tract disease in terms of immunotherapy. I do think there is Checkmate study was negative with nivolumab giving it adjuvantly. That being said, I do think it may have value. I think we were talking about EV Pembro, for example. That definitely is something which is getting some interest, both in bladder and in upper tract disease as well. Obviously, we need better prospective study to look at it, but I do think there is value of considering either chemo or chemo IO, and I think that's probably where the field is going to go in the months and years to come.
Yeah, there are not many patients with upper tract included in this study.
Exactly correct.
So we probably know that perhaps the biology is different, right?
Yeah, and it's exactly to your point. If you look at, neoadjuvant trials in bladder and upper tract, we know response rates are very different. They're much inferior in upper tract disease than they are in bladder. 10-15% versus 30 to 35% CR rate. We clearly know the mutations, genomic profiling studies have shown the mutations are different. We have a higher incidence of FGFR3 mutations in the upper tract versus in the bladder, where those are less frequently seen. So I think it is a unique tumor type that, although much of the paradigm of how we treated it was based on bladder cancer, we probably need to fine tune much of what we do. I'm very excited also with what's being done now with some of these novel drug delivery systems in the upper tract for non-invasive disease. I think there's going to be a lot of interesting things that are going to come out in the next year or two.
Hey, thank you so much for being here with us.
Thank you so much. Pleasure.
E continue acompanhando a TV SBU na cobertura do 16º Congresso Internacional de Uro-oncologia aqui em São Paulo.